All right, everyone. Thanks so much for joining us today. I've got Lily Nichols here with Real Food for Gestational Diabetes, and I'm really excited to be talking to her today. We've actually, full disclosure for everybody, we've tried to do this interview several times, and we've had too many technical difficulties. But today it's going to work. So I'm glad to have you back, and really thankful for your patience in working with us. How you doing today?
I'm doing great. How are you, Marc?
I'm doing good. So I am, and in that time frame that we've been working out our kinks on our end, I've had a chance to not only get your book, but go over your book. So thank you so much.
Nice. Good.
Um, so that's been nice, and have been using it as a resource and referring patients to it in the practice. So that's been great. So Lily, why don't you tell everybody a little bit about yourself? Let's start there.
Sure. Well, what do you want to know?
How you got involved in this line of work?
Sure. So it's kind of funny. I got into gestational diabetes pretty early in my career. I had the opportunity to work with the California Diabetes and Pregnancy Program, which is also called Sweet Success, to help revise their guidelines for care. So I sat on a board of other dietitians in the state to help come up with the nutrition and exercise guidelines to treat gestational diabetes. And we also did a lot of professional training. We had affiliate clinics who would follow our guidelines because we're a little more progressive than what the rest of the country does, so people can pick and choose to follow our guidelines or not.
Okay.
And then from there, I ended up working with one of the doctors with the organization who's a really well-known perinatologist in Los Angeles who specialized in gestational diabetes for like more than 30 years. So she's kind of like the expert's expert who, lectures internationally on the topic. So I was her, sole nutritionist and diabetes educator and worked with all of her clients. And it was really interesting because I got to see, well, not only working in a busy perinatology practice, you pick up a lot that's missing just from, reading books or working in research. So you pick up a lot clinically, but also I was able to implement the guidelines that we had helped create and see where they worked, where they didn't, where the holes are, and sort of just get my feet wet in the whole gestational diabetes thing. And that was really where I kind of started putting together, how could we fix these guidelines to work better? Where there's like nutritional gaps for these pregnant women, because the gestational diabetes guidelines aren't exactly, they're reflective of the rest of the country's nutrition guidelines.
Sure.
At a basic level. So, they're kind of focused on low fat. They leave out a lot of nutrient dense foods. And that's what led me to come up with my own version of the guidelines that I've found to work a lot better, reduce the need for medications and insulin, and overall just result in really healthy pregnancies and really healthy babies.
Great, great. So when you developed this kind of new perspective and guideline for gestational diabetes, were you able to implement it clinically with your nutrition work where you were working?
Yep.
Awesome. So
Yep.
she let you do that.
I was able to basically, the nice thing about, being a registered dietitian is a sort of a frustrating career path if you have a real food ancestral approach, because the conventional training in dietetics is pretty bad.
Yeah, it's the old food pyramid.
Exactly. Even though that's been thrown out, it's still like there's this obsessive focus on low fat. The recommendations are fairly high carb. There's specific nutrients that they kind of just like leave out because we're so focused on one or the other. Like, it just doesn't take a very holistic view. The nice thing about working in private practice, and especially when you have some autonomy, is you have control over what type of stuff you teach. So I came up with my own handouts. I came up with my own way of teaching the diabetes class. And what I found is, and this is the same for a lot of dietitians who have a similar approach to me, as long as your patients are getting the results, the doctors don't care. Like,
Right.
if their blood sugar is well controlled, if they are on insulin and medication and that's well managed and stable, if they're having healthy babies, if everything is going as planned, then no big deal. They just happen to be eating a lot less processed carbohydrates, not eating artificial sweeteners. They are totally allowed to have, full fat foods. They're encouraged to have, plenty of different well-raised animal foods in their diet, and they just happen to be leaving out all the junk. And then everything kind of fixes itself.
Sure.
So yeah, I did have free range to implement that and really see the benefits.
That's great. That's great. Yeah, I've noticed, I've had several patients recently who have, we've been concerned potentially about gestational diabetes, and they, when they go take their classes, I forewarn them about, like, this is what you're probably going to be told, and I'm not necessarily a proponent of it. And sure enough, that's what they're told, which is unfortunate. And I've gotten interestingly enough, recently I've gotten a lot of pushback about what I've been asking them to do, and really just telling them, this is what I want you to follow. Pick up the book and follow the nutritional guidelines.
I'm curious, where has been the pushback?
The pushback has been that it's a lot more fun to eat more carbs.
Right.
Right? So the pushback has been, well, I haven't been diagnosed with gestational diabetes yet, so do I really need it? Do I really need to make these changes? And or the other one was, but that's no fun. It's boring.
Mm-hmm.
The dietary recommendations are boring. They're no fun. I'm like, yeah, but our goal right now is really to have not only a healthy pregnancy, but a healthy baby. So,
right.
I'm trying to to let them know what the priority is here. It's not always, as you probably know, food, we are attached to our food, and it's a hard thing to change, and people don't like making those changes. So it's just been, I haven't in the past had that difficulty, but I've been having that difficulty in recent times. So,
well, I mean, I'll tell you, in my very early clinical work, I worked with women who are kind of carboholics, so to speak. I mean, so lots of grains, like still drinking juice and soda, candy and sweets. And what I would try to do in my teaching is have the focus on all the delicious foods they can eat more of.
Right.
And they'd be like, whoa, I can have butter and bacon, and like I can have yolks with the eggs, and I can have cheese, and I can have, they'd be like, oh, avocado, I get to have that. Oh, that's fantastic. It's like, okay, yeah, but just, limit the tortillas you're having at the meal, or, serve yourself a smaller portion of rice, or what if you do, half zucchini noodles, half regular pasta. Like, it kind of, sometimes you have to go with the incremental changes, and the big ones that just need to be cut out are the sweeteners, the super, both the super refined grain products and all the sources of hidden sugar, including the naturally occurring sugars like juice.
Right.
That's like one of the biggest ones. So if you have to start anywhere, start there. And if they're checking their blood sugar, they can see how their blood sugar does just with a slight decrease in added sugars. And sometimes that's enough. And then some women will choose to continue to eat more carbohydrates. And if it ends up that they, need to have medication or insulin to manage it, that's a choice that you can make. And that's not a bad thing. It's like the most important thing is that the blood sugar levels aren't getting totally out of control, because that's where all the risks come in. So you have options. And in the book, I give, different levels of carbohydrate plans that are, 150, one of the plans I suggest is 150 grams of carbs. That's it's a pretty decent amount of carbohydrates. Yeah. It's not super, super low. And some women will be able to sort of, get away with that and still have normal blood sugar. And some women, will need to go a little bit lower. So I know it's a tricky one, because carbs are yummy. They're just good. And we most of us grew up with, cereal and juice and pasta and all this stuff that's just pretty much pure starch or pure sugar. And it's not great for us, but it's hard to break the habit.
Sure. So we kind of jumped ahead a little bit. Can you tell everyone who's watching what gestational diabetes is?
Oh, yes, we should probably go over that, huh? So gestational diabetes is, there's a couple ways to define it. It's diabetes that is either first diagnosed or that first develops during pregnancy. It can also be called insulin resistance or carbohydrate intolerance during pregnancy, which is my preferred way to refer to it because it points a finger at what's going on inside of your body and what you need to do to fix it or to manage it, basically. So if insulin resistance essentially is when your body is less able to manage your blood sugar well. So when our blood sugar goes up, normally our body releases insulin to take that sugar out of our bloodstream and bring it into our cells to be used as energy. But if you're insulin resistant, you can have high blood sugar and high insulin levels, and they can't talk to each other. So they just kind of like hang out here. You have high blood sugar going on, and your body has to try to pump out even more insulin to overcome that insulin resistance and lower your blood sugar back down. So the key to helping with that is not overeating carbohydrates so we don't have excessive blood sugar and excessive insulin levels. So that's kind of the short end of the story.
Okay, and let's say someone is not aware, they're diagnosed late, or they don't want to, they to make the decision on their own that like, hey, I'm not going to really do much to change my diet, and this is the way it is. What can happen? They move on, and what happens to them next?
Exactly. Well, there can be some issues. I mean, for the mom alone, having high blood sugar isn't great because that tends to lead to a lot of other pregnancy complications. One of the big ones is preeclampsia, because high blood sugar and high blood pressure are actually very closely linked. For the baby specifically, they can be born too large at birth. Essentially, if they're exposed to a lot of sugar throughout the pregnancy, at a certain point, their pancreas will start producing insulin, and they will end up with high insulin levels to help combat that high blood sugar. And what that does is, when you're having an excessive amount of sugar come in and they're not able to use up all that energy, it gets stored as fat. So these babies get born too large, not because they're ridiculously healthy, but because they've been exposed to too much sugar.
Sure.
And that in itself is where most of the issues with babies born to moms with gestational diabetes come into play, is the excessive insulin levels. So large babies are more likely to have trouble at delivery because the shoulders can grow too large and get stuck during vaginal delivery, which can cause shoulder dystocia. They can be born with hypoglycemia because when you think about it, these babies are adapted to high levels of sugar. They have high levels of insulin. When they're delivered and you cut the cord, like quite literally cut the cord and cut off that sugar supply, their insulin levels remain high without that source of sugar coming in.
Right.
And then their blood sugar can crash, and that can be, that can be life-threatening. That could kill the baby. Sometimes it's not that serious, but many times it does require a stay in the neonatal intensive care unit. They can have issues with lung development because sugar impairs that. At its worst, gestational diabetes, when it's really uncontrolled, can result in stillbirth. Essentially, high blood sugar can result in hypoxia or not enough oxygen getting to the baby, and that can cause fetal death. I mean, it can be really serious. Generally, the consequences are a little bit more moderate, like the macrosomia. But the reason that that's a problem, more than just a difficult delivery or the hypoglycemia at birth, is that we know now that can permanently change a child's metabolism. So essentially, there are certain genes that are turned on or turned off by high blood sugar, and some of those are related to their lifetime risk of becoming overweight or developing type 2 diabetes in their lifetime. So for kids born to moms with uncontrolled gestational diabetes, they face a 6-fold higher risk of having blood sugar problems or even type 2 diabetes by the time they're adolescents. And that's the concerning part to me, because it's not like this just happened during your pregnancy and then disappears and everything's fine and maybe there's some complications at birth, but beyond that you're okay. It's like this can affect your child for the rest of their life. So that's where managing the blood sugars becomes really important.
Absolutely. And I would actually even take it a step further. Not only affects their children, but probably is going to affect their grandchildren.
Their children's children,
Yeah.
and children's children, and it keeps going.
Yeah.
I mean, there's actually a term for it, the transgenerational cycle of disease. It's in the research, transgenerational cycle of obesity or diabetes, fill in the blank, and it's definitely passed on.
Yeah, absolutely. And that's, where a lot of the research is coming out, and a lot of what we've been talking about, at least in probably our community, is, the role of epigenetics on health. And that's where this lineage comes in, this generational passing on of bad genes, so to speak, really changes our healthcare system, and that's really what's had such a big impact on our current healthcare system right now, where this generation coming up is going to live a shorter lifespan, theoretically, is at least what they say, than the generation before that, and that's never happened before.
Yes, and unfortunately, a lot of the public policy has been focused on preventing childhood obesity by trying to change the school lunch program or change the snacks provided in schools, and that's all fine. But if these children are born with impairment to their insulin and blood sugar regulation systems, it's like fighting the fire with fire. We have to start earlier.
Yeah, it's already done. Now we just need to kind of put a Band-Aid on it and really just try to manage it more than anything at that point. If you really want to make a change, you got to do it before.
Exactly.
Which is why
now we're making
treating
it sound
gestation
like super doom and gloom.
No, but which is why treating gestational diabetes is so important.
A lot of genetic stuff, we can overcome quote unquote bad genes with really good lifestyle habits. So it's like, yeah, obviously we should care about what we're feeding our kids, but I agree with you. We have to kind of back up and look at this as not as the kid's fault for overeating sugar.
Right.
It's like this goes back, like this might precede them. If these kids have super high insulin levels already and are frequently experiencing low blood sugar, they're going to have cravings for more things that are sweet and filled with carbohydrates, which further fuels the cycle and further makes that beta cell burnout inevitable and quicker to happen. So it's completely abnormal that we have such a high rate of type 2 diabetes and prediabetes in children. I mean, that's absurd. And so we can't, it doesn't even make sense to be like, oh, okay, well, in your 5 years of eating food, you now have somehow developed this disease. It's like, that doesn't make sense. This had to have, type 2 diabetes used to be adult onset diabetes for a reason. It takes decades of abuse to your pancreas and blood sugar system for it to develop. So there's other stuff going on with that.
So we kind of went down the path of all the bad things. Let's talk about some of the good stuff. So what are some of the things that as a woman and a couple for that matter are trying to, they're getting ready, they're going, they decide they want to have a family, they're starting to get ready to conceive. What could they do on their end before they're even pregnant to prevent something like this?
Sure. That's always the question. How can we prevent gestational diabetes, or how can we prevent some of these problems? At the simplest level, we have to bring our focus back to real food, because the more nutrient dense your diet is, the less likely that you're going to have issues conceiving or issues with the pregnancy. So, and dad's diet matters too. Actually, we don't have a ton of human studies on it, but in terms of rat studies, they've shown that a father's diet does impact the rat pups' disease risk.
Sure.
So it's likely the same thing in humans. So we're always focusing on the mom so much, but dads need to lay off the pizza, lay off the soda too. But one of the big things that they can do in terms of preventing gestational diabetes, the biggest one is trying to maintain a normal weight before they conceive. They've found that at least 40% of gestational diabetes can be attributed directly to preconception overweight. Because essentially when you're overweight, you already have some level of insulin resistance in your body, which only gets worse during the pregnancy. So the biggest thing is trying to maintain a normal weight before you conceive. The other thing is having regular exercise can also drop the risk. So there's one study where they looked at women in the year prior to conception, all the way through their pregnancies, and women who exercised regularly, which for them I think it was like 2 to 3 times per week, not excessive. In the year prior to conception, all the way through 20 weeks of their pregnancy, had up to a 78% reduced risk of developing gestational diabetes, which is huge. I mean, that's like, that would be magical if we had a pill that did that. I mean, it's pretty incredible. Another thing that can help is having adequate protein consumption. And this is kind of a new one out of University of California, San Francisco Medical Center. They found that having adequate protein consumption during the first trimester may protect against the development of gestational diabetes. And this one's kind of cool. Essentially, during pregnancy, the pancreas starts producing more beta cells so it can produce more insulin during the pregnancy. So by the 10th week of pregnancy, insulin levels are triple or even higher what they are preconception. And that's because as a natural adaptation to pregnancy, insulin resistance goes up. And then insulin levels go up as well, because our body is just obsessive about keeping our blood sugar as low as possible during pregnancy, but also shunting as many nutrients as possible to the baby. So what happens is if the diet is deficient in protein, potentially the beta cells don't get the nutrients they need to multiply, and then by the time you're in late pregnancy and the insulin resistance is high, your pancreas doesn't have the ability to pump out enough insulin to overlap with high blood sugar and gestational diabetes. So that one's new and kind of neat. Another thing is vitamin D deficiency. That one's big. I mean, there's many different nutrients that play a role in insulin resistance, but vitamin D deficiency is much more common in gestational diabetes, and they've found that women who are deficient have a 3.7-fold increased risk of gestational diabetes compared to women who come into pregnancy with normal vitamin D levels. Magnesium plays a role. I mean, there's a variety of nutrients that play a role in insulin resistance, but vitamin D is huge, and they've shown up to 85% of pregnant women are deficient, just like the rest of the population. So if both partners can get their vitamin D levels adequate, that's awesome.
That's interesting, because I know there's another research study with regards to vitamin D that mentions how much it plays a role in preventing, or if it's deficient, potentially helping to promote preterm labor. And so it's interesting, yes, because the two can also go together.
They can go together. Yeah. It's also linked to preeclampsia.
Right.
There's a really, really good study on it. I'm trying to remember the journal that it's in. I think it was from 2011. Hollis. I think it was Hollis or Holic. I'm trying to remember there's two vitamin D researchers that are like really big, and one's Hollis and one's Holic, and I always mix them up. But anyways, it was a randomized controlled trial on vitamin D supplementation during pregnancy, because this has been so controversial. And essentially they looked at different levels of supplementation up to 4,000 IUs per day, and the 4,000 IU per day group had the lowest rates of pregnancy complications. Their infants had the highest chances of having normal vitamin D levels compared to the ones that were given these paltry, what's currently the recommendation. And now they're finding that there is a statistical error or a calculation error when they came up with the Institute of Medicine vitamin D recommendations that underestimated the required vitamin D dose tenfold.
Yeah. So
instead of 600 IUs, we probably require 6,000 IUs, which is consistent with all the supplementation research out there. But unfortunately, the public policy doesn't reflect that per usual. So it's like, you got to take matters into your own hands, get your vitamin D levels checked, and supplement appropriately.
Yeah, I had a patient who was I was concerned about gestational diabetes, and she sees a very good OB here that I really like, but I had her, because of that exact research, I put all my pregnant patients on 4,000 IUs of vitamin D.
Yeah.
During their pregnancy, at least, and he was concerned that she was taking too much, and he wanted her off the medication. And I said, well, here's the research study. I emailed it to her, and I was like, this is why I don't want you off of it, and you're welcome to show it to him if you like.
Yeah, I
Yeah.
know. We get into it's really frustrating because there's so much incorrect information about vitamin D. I did a fairly large and lengthy presentation on vitamin D at a gestational diabetes conference not too long ago. And I mean, because it's so controversial, there was a reference on every single slide. I think I had maybe 50 slides and I had over 60 references. I mean, it's just out of control, but the research is pretty strong on vitamin D. And so if they want to wait for, us to have 10 randomized controlled trials, then we're missing a whole generation of moms getting adequate vitamin D during their pregnancy, and then these carryover effects. There was one study that was really interesting. I don't have it in front of me, but they looked at women with normal vitamin D levels and deficient vitamin D levels and looked at their average fasting blood sugar, average post-meal blood sugars at 1 hour and 2 hour. And they were significantly lower in the moms who had normal levels. I mean, lower enough that, or enough of a decrease that would be the difference between a mom requiring medication or not to manage her blood sugar. I mean, it was really clear.
Significant.
So, yeah. So again, it's just one of the other nutrients we need to pay attention to.
Yeah, I mean, I think that's a big one. You mentioned protein, and I think protein for me, I find that in general, patients don't eat enough protein, especially in their first trimester. So it was interesting that you noted it in relationship to their first trimester, because I find that's the time where they're craving all their carbs. So they end up, relying on all the comfort foods, which are carb filled, and decreasing their protein intake. So I'm trying to, offset that as much as I can.
It's a tough one with the nausea. And I've talked with some people who are experts in hyperemesis gravidarum, where there's that, it's morning sickness, like to an extreme, where you can't keep any food down and sometimes you need to be hospitalized and whatnot. And she was asking me, is there a link between hyperemesis and gestational diabetes? And when we were first chatting about it, I was like, I don't know, that wouldn't make sense because a lot of the risk factors for the two don't line up.
Mm-hmm.
But she was seeing that more of the moms who have HG were getting gestational diabetes later. And then I came across this protein research and I was like, that makes sense. I mean, we don't know for sure if HG and gestational diabetes are linked, but that would potentially explain it. The pancreas isn't able to adapt as it should.
Yeah, so I agree. And one of the fascinating things for me, because you also mentioned exercise, and we know that exercise can have such a profound effect on so much in the body. A lot of the fertility patients that I see who are going through in vitro fertilization, their doctors, and sometimes I'm guilty of it as well, we're reducing their exercise regimen or being cautious about it when they're going through in vitro because of medication and hyperstimulation. And then once they get pregnant, everyone's so concerned about holding the pregnancy. So, don't do too much and don't overexercise and don't do all these things. And the time that they're able to start exercising more is really in the second trimester. So they have this huge gap of time where they've reduced their exercise habits dramatically, which I could see having this profound effect on their blood sugar. Yeah.
Yes, it does, because exercise plays a significant role in both the fasting and the after meal numbers. And the exercise thing is a bit controversial, especially when you're dealing with fertility treatments. But I mean, on one hand, you don't want to do anything too strenuous, because that strenuous exercise is essentially a source of stress on the body. So unless you have adequate time to rest and adapt, it's okay. But the research on moderate exercise during pregnancy is quite positive, and the benefits tend to outweigh the risks. So aside from doing exercises that are, have a lot of bouncing or jumping, or where the heart rate is getting maybe too excessive, like they're running out of breath and whatnot, those are probably best avoided. But maybe more moderate activities like walking or Pilates or prenatal yoga. I mean, these are all great for the mind-body, reducing stress. The insulin resistance goes down. But also, if you think about it in one way, as you increase circulation, you're increasing nutrient flow. and waste removal from the embryo or from the fetus. So those are good things if you don't take it to an extreme.
Sure, sure. Yeah, it's all about balance.
Yeah, because we have some women who are, crazy over-exercisers too, and that's no good. That lowers fertility. So there's a fine line here.
There is absolutely. So one of the things that I've loved about your book is that it really helps clear up the diet portion of things and really kind of gives them something to follow and guidelines and rules. Can you just touch on some of those things for everyone who's watching right now? Really, they're going to get the meat of it when they pick up the book, but if just some little bits would be great.
Yep, sure. So I'll just say the main thing is that you want to start checking your blood sugar so you can identify where your problem times of the day are and start figuring out how food uniquely affects your blood sugar, because it's going to be different for everybody on some level. But in terms of a general rule, you want to pay most attention, at least at first, at identifying which foods in your diet contain the most carbohydrates, so you understand that those are the foods that are going to raise your blood sugar the most. And generally, you want to eat less of those foods to a certain extent and get more of your foods coming from meats, eggs, fish, nuts and seeds. If you tolerate dairy products, some of the lower carb, higher fat, higher protein dairy products like Greek yogurt and cheese. So just kind of shift the balance in what you're emphasizing. Obviously, plenty of non-starchy vegetables. Those should make up a good portion of your food intake as well. When you do consume foods that are high in carbohydrates, like sweet potato, or if you eat grains, a piece of bread, you can reduce the impact on your blood sugar by matching that food with plenty of fat and protein. So I call it naked carbs in the book. Like, don't eat naked carbs. They're like a blood sugar bomb. So don't have the apple by itself. Have the apple with some almonds, or have the apple with some cheese, or have the apple with, some peanut butter maybe, or almond butter, so that you don't have the same spike in your blood sugar levels. Trying to get most of your carbohydrates from the less concentrated sources will naturally help. So non-starchy vegetables, nuts and seeds, they all have carbs, but they're not naked. They're matched already with fat and protein. Low sugar fruit like berries, the full fat Greek yogurt, cheese, heavy cream, those are all going to be much more balanced in the fat, fiber, and protein than they are just pure carbohydrates. So that helps big time. Let's see. And then, like I said, reducing sugars. So I'm just going to point out juice because everybody knows the obvious. I don't need to mention like soda and cake and candy and whatever, but there's a lot of naturally occurring sources of sugar that are just super, super concentrated, and we don't realize how much we're getting from them and how much they impact our blood sugar. So I just picked up the other day a green machine juice. I don't know if you've seen them. They're like the Naked Juice Company
green machine
green drink.
Yeah.
And a whole bottle of that, it's only 15 ounces. It has 63 grams of carbohydrates.
Yeah.
That's the same amount of carbs as one of those giant bagels. I mean, it's just insane. So even though those sugars and carbohydrates are coming from fruits and vegetables, they're highly concentrated. The fiber has been removed because it's been juice, and because it's fruits and vegetables, there's basically no protein and fat in there. So that's a disaster for your blood sugar.
Right.
Eat your fruit. Don't drink it. If you're going to do juice because you want to get all the benefits from juice, do mostly green, non-starchy vegetables, like a base of cucumber or celery, and add in all your greens and whatever. That's fantastic. It's when there's, 3 apples going along with it, or, 2 cups of pineapple going in there. That's when you get the huge surge in your blood sugar levels. And then finally, just, these are all kind of basic things, but I highly recommend mindful eating in lieu of obsessive carbohydrate counting, and definitely no calorie counting. I'm a big advocate of avoiding that as much as possible. But mindful eating is really helpful, where you go into your meals being relatively calm, you pay attention to your hunger and fullness levels both before, during, and after eating, and that naturally usually helps you choose the right amounts and combinations of foods for you. If you feel hungry 30 minutes after eating, for example, you either didn't eat enough, or maybe you didn't get enough fat and protein at the meal to help stabilize you. Like normally, if you're hungry 30 minutes after eating something, you had a spike and a drop in your blood sugar, and you want this little gentle roller coaster, So it's just about shifting the balance.
That's really great information. A lot of the same things that I talk about with patients, so I love to hear it when someone else says the same thing.
Exactly.
Great. Well, really, thank you so much for your time, and this was a fun conversation, so I appreciate it. I enjoyed it a lot. If someone wants to pick up your book, or someone wants to reach out to you, how can they do that?
Sure. You can find the book on Amazon, and if you go to realfoodforgd.com, there's also some free resources there, including some of these tips to help control your blood sugar if you're not yet ready to buy the book. And then you can find more about me personally and get into my personal blog at pilatesnutritionist.com. And I post a new post every week. My weekly newsletter is pretty popular, so that's another place to find me. And then for moms who do have gestational diabetes, I am putting together a training program for them. So it'll be a group program with other moms who have gestational diabetes that's operated fully online. So you can take the guidelines from the book and then customize them to yourself. So it's just a lot more hand-holding, a lot more support, a lot more connection with other moms who are going through this. Because for the most part, I mean, if you're pregnant, you're lucky if you have other close friends that are pregnant. It's even more unlikely that you're going to have close friends who are pregnant and also have gestational diabetes.
Sure.
So it can be kind of a lonely road, So this will be a good way to connect with other moms.
That's great. We're going to put all that information below the video, and we do have a link to your book on our website, on our Amazon recommended book list as well. So you can find and reach out to Lily in all of those ways. And once again, thanks so much.
Great. Thank you for having me again.
Yeah, my pleasure. We'll talk soon. Hi, I'm Marc Sklar, the Fertility Expert, and if you're getting ready for an IVF transfer and have been told that you need bed rest, here are my thoughts on bed rest. Really, there's no scientific evidence or research to support a patient being on bed rest after an IVF transfer. There are many countries that don't promote bed rest whatsoever after IVF transfer. Those patients come in for an IVF transfer, they sometimes even go right back to work. In the United States, it's mixed. There's a lot of patients